Well, welcome everyone. I want to welcome all of our attendees, including our first timers and our returning members. Welcome to everyone. I want to also recognize our PBNSG team. Paul Chatlin, the founder of PBNSG, in the face of an amazing inspirational story of going from nearly dying to strong, vibrant, and healthy through a plant-based lifestyle. To Marion Treese, Administrative Director, Brian Nyquist, Director of Technology, and Megan Burt, Director of Support Groups. We also have an amazing team of specialized hosts who each lead their own monthly support group meeting through our membership platform. And as Paul likes to say, we are together as one, and we have the same passion for helping others find success in this plant-based lifestyle. My name is Stephanie Spencer. I'm an RN as well as Dr. Trapp, and I'm the owner of Natural State of Health Plant-Based Wellness. I have a 21-day plant-based challenge course, online course, and I'm passionate about bringing plant-based nutrition to people that have never heard anything about it anymore. My background's in cardiology, and I used to run a heart failure clinic for 20 years. So it's a lot of fun. I've been plant-based for 3 years now, and we converted because my husband had pre-diabetes. Basically, in my line of work in cardiology, I didn't realize there's people that aren't diabetic in the outside world until I got to the plant-based line of work. But yeah, it is a lot of fun. Nothing excites me more than just being a part of this whole plant-based movement. So for those of you that are new to our events, PBNSG stands for Plant-Based Nutrition Support Group. We are a nonprofit organization dedicated to evidence-based education and advocacy of plant-based whole foods nutrition to help individuals prevent or reverse chronic disease and achieve optimal health. As you may know, PBNSG is well into our new membership platform, which gives access to live virtual events, cooking demos, support group meetings, event recordings, and more. Please pass along this information to family and friends. More information can be found at pbnsg.org. And additionally, visit our website to find upcoming events, subscribe to our newsletter, and visit our shop page to order merchandise, which is where you'll also find our new cookbook, Perfectly Plant-Based, a curated collection of over 100 whole food plant-based, no oil recipes by our more than 20 contributing PBNSG chefs. And please know that PBNSG is in the process of offering a whole foods, no oil, plant-based coaching option for individuals who would like more support in this lifestyle. More details are to come. We look to start offering that in early 2022. Don't forget that our free monthly virtual community support group meetings are the second Thursday of each month. Registration for this monthly meeting can be found at pbnsg.org under support groups. And those of you who use social media can find PBNSG on Facebook, Instagram, Twitter, TikTok, and YouTube. So tonight, I would like to introduce today's presenter, Dr. Caroline Trapp, and she is going to be presenting on remission of type 2 diabetes. Most clinicians were taught that type 2 diabetes is a progressive disease, and that's what I always thought. And once a patient has it, they'll always have it. Many new members of PBNSG know that this is not the case. In this presentation, we'll talk about how diabetes is defined, how remission is defined, and how it can be achieved. If you've got a success story, bring it to inspire others. For more than 25 years, Dr. Trapp has had a special interest in diabetes, recognizing early on that lifestyle played a huge role. As Director of Diabetes Education and Care with the Physicians Committee for Responsible Medicine for almost 15 years, she helped to develop and implement many clinician and patient educational programs that seek to change the way that type 2 diabetes is addressed, advocating for less reliance on medication. That's exactly what we need. As a nurse practitioner caring for people with diabetes, she was invited to provide oral testimony to the U.S. Dietary Guidelines Advisory Committee in 2015 and 2020. Recently retired, she serves as a member of the Physicians Committee for Responsible Medicine's Scientific Advisory Board, the American College of Lifestyle Medicine's Diabetes Task Force, and is a consultant to a nutritional research project with the Navajo Nation. So without further ado, I present to you all Dr. Caroline Trapp. Yay.
Thank you very much, Stephanie, and thank you everybody who's joining us today. I hope wherever you are warm and cozy. Just like Arkansas, we've been hit hard in Michigan with snow these last 2 days. And It was an easy day for me to stay inside and pull some things together to share with you today. So I'm going to go ahead and share my screen. I've put together some tiles to illustrate some of the important concepts I want to cover today. But I titled this talk, Remission of Type 2 Diabetes, Join the Club. And I'm wondering, you know what, I can't see in the chat. So Stephanie, maybe if you could just keep
I
an
will,
eye.
yeah, I'll monitor
Okay,
the
good.
chat.
But I'm wondering if we have anybody on the phone who's actually experienced remission of their type 2 diabetes. Oh, good. I see a
My
hand up.
husband.
Okay, great. So I'm going to ask you to talk about your experience a little bit further in, but I most of all, I wanted to share this message that this is not a disease that needs to progress. So let's see if I can move the slides. Okay, so just a little background in diabetes. Of course, uncontrolled diabetes leads to all kinds of horrible complications. So of course we want to arrest it. The primary underlying problem in diabetes we think is related to the pancreas that makes insulin, and insulin when we eat is released into the bloodstream, and it helps to push sugar or glucose into our muscle cells where it can be used for fuel and for energy. And that's a really simplistic definition, but so much of diabetes we talk about is talking about sugar, right? We're going to talk tonight about why that's shouldn't be the primary focus. There are different types of diabetes, and this is a busy slide, but basically it was just a reminder for me to remind you that I'm not going to be talking about remission of type 1 diabetes, which is an autoimmune disease in which the pancreas is no longer able to produce insulin at all. A plant-based diet has been shown to be beneficial to people with type 1 diabetes. They're able to often greatly reduce the amount of insulin they need to inject, and that can be good for a lot of reasons. But our focus today is type 2 diabetes. And in type 2, the body's making plenty of insulin, especially early on in the disease, but the muscle cells are resistant to insulin and aren't able to use it properly. Gestational diabetes is another type of diabetes. This occurs during pregnancy. And I've got some great stories about women who found out they had diabetes during their pregnancy, and with a plant-based diet were able to reverse it and get off all medication. So it's good for everybody. So how is type 2 diabetes usually treated? Well, at diagnosis, your clinician might tell you to eat a healthy diet, lose weight if you're overweight, and to get some exercise. And that is all good advice. Often the specifics about what to eat or how to lose weight are lacking or aren't the most up to date, unfortunately. And the American Diabetes Association recommends at the time of diagnosis that people are started on medication, and metformin is usually the pill that's prescribed unless there's a contraindication to it. And metformin seems like a pretty benign medication, and in that it's safe for most people. It's fairly well tolerated. Some people get some gastric issues when they first start on it, but over time that usually tends to get better. It's cheap, and it just often seems like everybody's on metformin, and that's because many people are. I will share with you though one concern, in that it was found here in the Great Lakes waters a few years ago, and environmental researchers found metformin was not being filtered out, and they found that there were endocrine issues, reproductive issues in minnows, the fish that they happened to study. Now, I've not seen anything further on this, but it just seems to me like one more reason that we want to try and minimize medication use and reduce and eliminate it whenever possible. So that's the first pill that's prescribed. And then if numbers don't get better, a second pill, a third pill are prescribed, and then even an injectable might be added. And the usual trajectory is to add more and more medications and to to stay on those medications. And in fact, let's see, I have here, there. This is the algorithm that's been developed by the American Diabetes Association. And this is very busy and I don't expect you to be able to read it, but basically it says first line therapy is metformin and comprehensive lifestyle interventions. And then if numbers don't get better, you can add a second agent, a third agent, and there are I think 12 different classes of medications for diabetes. So let me just go back here for a minute. So how are most people with type 2 diabetes treated? Well, as you can see in this chart, there are, for the most part, most people are on medications. 84% of people are on insulin or oral agents or injectables or some combinations of these. Only 16% in this particular survey were not on any medication at all. And this is from almost 10 years ago. However, I don't think that's gotten any better because in these last 10 years, we've had newer medications come out and they're widely prescribed. So I will admit that I was very proud of my expertise with medications, and my practice was to prescribe medications really aggressively to try and get good control of diabetes. And I wrote a lot of prescriptions. And these are pictures from the sample closet and the refrigerator in the practice that I was a part of for 20 some years. Pharmaceutical companies provide all of these samples. And I used to think that I was really doing my patients a benefit, giving them these samples, these free medications, right, to try these out before they had to go to the pharmacy. However, I learned that pharmaceutical companies don't consider this charity. It's actually in their marketing budget, and they spend millions of dollars on these samples. Are you familiar with this expression, if all you have is a hammer, everything looks like a nail? And, if this is the only tool in the arsenal or the one that we learn the most about, it's the one that tends to get used. So have you heard of this, the oculoglycemic reflex that doctors and nurse practitioners and PAs have? Well, if you haven't heard of it, it's because I made it up. And what I'm referring to here is oculo is eyes and glycemic is blood sugar. And the reflex is when a clinician sees a high blood sugar on a chart or on a patient logbook, the reflex is to write a prescription. And I suffered from this for many, many, many years, but I'm glad to say I was able to overcome it. And I'm hoping that you and your clinicians can overcome this as well. Why? Well, there are a number of concerns about medications. One is this fancy word polypharmacy, and this just means multiple medications. And in one study, over 30% of elderly patients have 6 or more prescribed medications. And I had learned, and this is still taught today, that anybody who's on 5 or more medications is at a very high risk of interactions from those medications. So polypharmacy is one concern. But there are a lot of other concerns with medications, including the costs, including side effects, and perhaps not even the outcomes that we want. So let's see, whoops, I'm sorry. So the truth is that most medications for diabetes are prescribed to treat symptoms, and they have not been shown to result in a longer or healthier life. And medications do not get at the underlying cause of diabetes. And I'll tell you that when I speak to groups of doctors, this is often like earth-shattering, right? This is not what anybody's learned. We've all been taught we're supposed to treat diabetes aggressively. When I speak to the plant-based nutrition support group, most of you are familiar with this already. You know that our, better living through pharmacology is really a beneficial to the pharmaceutical companies, but not necessarily to individuals. So if this route leaves you feeling empty, let's talk about some alternatives. And this is a study that many of you will be familiar with. I just want to make sure you know about it if you haven't heard about it before. Dr. Neil Barnard and his group were funded by the National Institutes of Health to compare a low-fat, plant-based vegan diet to the conventional diet for diabetes. And that was a diet of portion control, basically. It was a randomized trial, so this is the gold standard of studies, and it compared a low-fat vegan diet to the American Diabetes Association dietary guidelines of the day. And at that time, that was a low-fat, but not as low as we go, and a portion control, low carbohydrate restricted diet. Now, I do want to say that although this was comparing a low-fat vegan diet, and we use the word vegan here because this was before the word plant-based came around, this was compared to the ADA guidelines of 2003. And just in case I forget to mention it later, the ADA does currently include a plant-based diet in their various approaches that have been approved for people with diabetes. So anyway, back to this particular study. It was a 22-week study with a 1-year follow-up. And what they found was here, the blue line is the vegan plant-based group and the red line is the ADA group. And this chart is looking at A1C reduction, and A1C is a measure of diabetes control. And you can see that from the week 0, both groups had a drop in A1C, but the plant-based group dropped significantly lower. Another important outcome from this study was drop in LDL cholesterol. And here you see a little bit of a drop in the ADA group, but a much more robust drop in the plant-based vegan group. And this is important because most people who have diabetes don't die of diabetes per se, they die of heart disease. And we know that cholesterol is a factor in heart disease. So a diet that not only lowers your blood sugar, but lowers your cholesterol is really beneficial. And if you've heard Dr. Barnard speak, you've heard him talk about some of the participants in the study who had really amazing, incredible outcomes. Vance not only lost a lot of weight, was able to get off his diabetes medications, but also had improvement in his erectile dysfunction. So that's for the men in the audience or the men in your life, that's a really important outcome to know about. Nancy was another study participant. She lost a lot of weight. She got off her diabetes medications. Her A1C dropped significantly. And also an added side effect, her arthritis improved dramatically. So Dr. Barnard likes to talk about the one of the underlying mechanisms that is linked to type 2 diabetes. And I definitely want to talk about this just for a minute. Again, I know those of you who've heard Dr. Barnard speak have heard him talk about this at length, and I'm hoping that you can recite this from memory. But as I mentioned at the onset, so often the focus is around sugar, but this little diagram really points to the importance of fat in our diet. So up at the top here, these little red dots represent glucose. And when we eat, glucose is released into the bloodstream, and it has to get through the glucose receptors on the muscle cell wall. And this big blue bubble represents a muscle cell. And in order for the glucose to get into the muscle cell, that's where insulin is involved. So when we start eating, even thinking about eating, our pancreas spits out a little bit of insulin, and it's represented by these keys, because a key fits into the insulin receptors on the muscle cell wall, and that opens these glucose receptors and allows the glucose to enter the cell, where it can get burned up for fuel. So that's what's happening in normal metabolism. That's the good process that's supposed to happen. In people who have type 1 diabetes, their problem is up here with the insulin. They are not making enough insulin, so they're not able to get glucose out of the bloodstream without injecting insulin. But in people who have type 2 diabetes, they are making plenty of insulin, The problem is thought to be with these insulin receptors. And often I was taught it's like gum in a lock, that the insulin can't fit in the key. But in reality, it's not gum, it's fat. And it is dietary fat. And Dr. Barnard says, we don't like to use simple names like fat. Instead, we call it intramyocellular lipid, and that becomes stored in the muscle cell, and it causes insulin resistance. So where does this fat come from? Well, it's from our diet. So the fat in beef, the fat in chicken, the fat in fish. Yes, fish contains a little bit of omega-3 fatty acids, the healthy, good fat, but it also contains saturated fat and cholesterol. Cheese is another big source of fat in the American diet. Oils such as canola oil, olive oil, even extra virgin olive oil. All of these contribute to people who have the genetic predisposition and can gunk up the works here. The good news is that when we reduce or eliminate these dietary fats within a matter of days or weeks, we can often turn things around, and insulin sensitivity is restored, and blood sugars come under control. And people can eat all of the healthy carbohydrates that they want, fruits and vegetables, whole grains and beans, because they're no longer eating all of this fat. Okay, and of course, we also know that making this dietary change benefits all sorts of other medical conditions as well. I was particularly interested in studies showing a link between meat consumption and the risk of diabetes, because this is not anything that I had ever learned in school. And there are a number of studies now, but perhaps one of the most robust is the systematic review that put together data from 12 different studies that found that people who have diabetes, people who regularly eat meat increase their risk of type 2 diabetes by 21%, and regular intake of processed meat increases the risk of diabetes by 41%. Now, why don't most people know this? Well, follow the money. And a really blatant example of this was in 2012, the American Diabetes Association ran this campaign that was funded by Boar's Head Meat. And do you know Boar's Head? They produce these lunch meats, right? Turkey and ham and whatever. And they gave $5 to the ADA for anybody who completed the online Take the Test, Know Your Score test to assess your risk for diabetes. And they were very upfront about this. That nobody was taking this test unknowingly donating. If it was marketed this way, if you take this test to see your risk for diabetes, Boar's Head Meat are going to donate to the ADA. And they did all of this big publicity around this. And the same month that this risk test was going on, this was the cover of Diabetes Forecast magazine. This was the ADA magazine for people with diabetes. And here's a holiday recipe featuring garlic and sage roast pork on the cover. So, was this a little bit of a conflict of interest? I would say so. And, I've attended a lot of ADA conferences, and where you walk through the exhibit hall, and the Cadbury Schweppes people are there, the people who produce 7-Up soda. And I mean, there's just a lot of food companies that are supporting the ADA in addition to pharmaceutical companies. So, I've been a longtime member of the ADA. I resent the dues, that my dues are going to support some of this. But I also like to stay up to date, and I like to be able to weigh in on their guidelines and other things. So for that reason, I continue to be an ADA member. But I want you to be aware that anybody who's ever gone to the ADA website and looked at the recipes has found they're very meat heavy. So to get on the road to health, we know that we need to unlearn some of the popular messages. So one of these is to avoid carbohydrates. Now, the one exception to this is anybody who's taking insulin at each meal and has been taught to count the amount of carbohydrates they're eating and then to dose their insulin based on the amount of carbs, they're still going to need to count their carbs. Another statement is everything is okay in moderation. And I found that's just not true. I learned from Dr. Barnard, he likes to say, well, cocaine is not okay in moderation. There are some things that are just not okay in moderation, but even certain foods are just better left off the plate completely. Another big one that I was taught is diabetes is a progressive disease and most people will need insulin. And I really think this is from Novo Nordisk or the companies that make Eli Lilly. This is what we were taught as clinicians. We were taught to teach people, oh, it's not your fault if you need insulin. It's just that diabetes is a progressive disease. And that's not to say that people are at fault. It's just that we haven't been giving people the right information. And here's another one. Diabetes medication is the best treatment. But we know that nobody's ever been cured by any medication for diabetes. At best, it's like a Band-Aid, right? It lowers blood sugar. So we've also been taught that intensive or tight control is the holy grail of diabetes management, and that it's all about numbers. So the American Diabetes Association says A1C should be below 7. That's considered good control. Or the American Association of Clinical Endocrinologists says that A1C below 6.5% is a good target. However, you may or may not know the American College of Physicians, which is the largest group of internists and is a well-respected organization that publishes all kinds of guidelines for their members, released guidelines in 2018 that said, the title of this was Hemoglobin A1C Targets for Glycemic Control with Pharmacologic Therapy for Non-Pregnant Adults with Type 2 Diabetes. And they stated that the evidence does not support using medications to aggressively lower A1C for most patients. And they said that they recommend greater use of lifestyle interventions. A1C reduction with lifestyle is safe and effective. Their key recommendations were, first of all, clinicians should discuss benefits and harms of medications and individualized care. Number 2, and this is a big one, A1C range of 7 to 8% is recommended for most patients. And I've added the words with type 2 diabetes medications. If you can get your A1C lower without medications, with just lifestyle, that's great. Lower the better. But if you're on medications, there's really, the American College of Physicians says, whether you're at 7.9 or 7.5 or 7.1, doesn't matter. You don't necessarily need to be below 7 in order to gain the benefits of less heart disease, less kidney disease, less stroke, etc. And you can avoid some of the risks of over-medication use.
Okay, we have a question here.
Sure.
From Dr. Trapp, and I kind of have this question too. So if this is from Lisa, if you are following a whole food plant-based diet, no SOS, and you are getting some high readings, should you be concerned? That's what my question is. They're saying A1C range of 7 to 8% is okay. If you're on a plant-based diet and can't get your A1C any lower, or are they saying like on whatever diet, like we don't have to worry about that? Because I was always of the belief that, high sugar damages your arteries. So you want to bring it lower. But anyway, yeah, yes. Give us your thought on that.
Well, you're correct. High sugar does damage arteries, but what the American College of Physicians is saying is that lowering A1C with medications to a level below 7%, it isn't any better than lowering it to below 8%. that most people with medication, that most people are at risk of problems from over medication use and won't necessarily avoid the complications that they're trying to avoid. That a target of 7 to 8% for most people is acceptable in terms of long-term complications and medication use. Now that said, lowering your A1C as low as you can get is ideal. And if you can go lower with diet, that's good. But in response to what Lisa said, in terms of an occasional high sugar, it really just depends on how often they're high and how high. So an A1C of 8% is equal to an average daily blood sugar of, I think, like 175 or 182. I don't remember exactly, but it's in that range. Mm-hmm. And that's a huge difference, right? From an average daily blood sugar of 100 or 120 that maybe, you've been trying to get. Mm-hmm. And the point is that an occasional high blood sugar, it is going to happen, but what you want to look at really is the A1C. And so, which gives you an idea of what's happening over time. And what an A1C really measures is what percentage of your red blood cells are covered in sugar, are fat and sticky, and can start damaging vessel walls. And that's what leads to the long-term complications of diabetes. So an occasional high blood sugar isn't necessarily going to cause a big spike in A1C.
And Dr. Trapp, I'm sorry. Yeah. Isn't also the issue that if you're aggressive with medications, especially in the elderly, you'll tend to have more hypoglycemic events? Absolutely. However, being like on a plant-based diet isn't going to give you hypoglycemic events.
Right. Yeah. Right. Yeah. So it's okay to be aggressive with your diet, but being aggressive with medication raises the risk of all kinds of problems.
Right.
One of which is just cost. And, I have a girlfriend who recently shared with me, she has pre-diabetes and she was put on a medication to lower her blood sugar, but also to help with weight loss. And that medication she didn't know this because she's not in the donut hole right now, but she's about to be. And that medication runs $700 or $800 a month. And, she's not using this healthy diet as an intervention, and wasn't aware, of how powerful this dietary intervention is. So anyway, let me move on. I hope I've addressed this concern and that I'm clear on this target range, because I know this is really different than what often have heard. The American College of Physicians also said that there should be no target A1C for the frail elderly and to treat symptoms only. Now, who are the frail elderly? Well, elderly can be defined as anybody 65 and older, or depending on, different guidelines might say 70 or 75, certainly some people within our organization. And frailty refers to other diseases, maybe, as well as people who are living alone, people who are at risk of low blood sugar, etc. Okay, so
Trapp, real quick, we've got more questions here for you about the sugars. How high is high is from Karen? How high is high and how often is occasional? How about 185 after a meal? And then let me give you another question. I'm concerned about my husband's A1C going to be higher than his last of 5.6 because since changing to whole food, plant-based, no SOS, he is having higher readings of 250 after meals. Any thoughts? So what about occasional spikes?
So with both of those, it really just depends on how often it's high. And I don't have, I guess maybe the best way to think about that is an A1C is measuring how much your red blood cells have become fat and sticky over the last 3 months, because our red blood cells live for about a 3-month period. So if, how often are you above that range of 180 in a 3-month period, or even just in a month, would be a good starting place. And if you're frequently above that range, then yeah, it should be treated. And whether that's with diet change or medication, I'm not saying don't use medication. I'm just saying that we may want to back off with how aggressively we lower blood sugar with medication. Okay. All right. So I also want to point out that this was from the American College of Physicians. The ADA and other organizations disagree with this recommendation. It's not surprising. So as a clinician, where does that leave us? Like, how do we handle when different professional organizations are making different recommendations? And we are exhorted to aggressively use medications to fix uncontrolled diabetes. And there's actually a phrase, clinical inertia. That's what we have. Us clinicians are told if we're not putting more medications on people when their blood sugars are high, then we have clinical inertia. We're not, moving things the direction they're supposed to be going. And then finally, we are judged by looking at intermediate outcomes like lab values like A1C, and we're not judged by, did we prevent hypoglycemia? Did we prevent long-term complications like kidney failure or heart disease? And that can be problematic too. We're rewarded for this short-term benefit, like lower blood sugars. So of course, we are incentivized to give people medication to lower their blood sugars because we know that works. And diet's hard, right? Or that's what we all thought before we got involved in the plant-based nutrition support group. Okay, so there are alternative approaches, and the American College of Lifestyle Medicine came out. I'm part of the task force with ACLM, and I helped to write this type 2 diabetes Bill of Rights. And again, I know this is a lot of small print, but I want to encourage you just to Google type 2 diabetes Bill of Rights, and you can get this. And I want to see this printed and framed on every medical office wall. And these are rights, like you have the right to be fully informed about all treatment options for type 2 diabetes before consenting to treatment. So I'm not going to read through all of these, but there are two in particular I want to draw your attention to. And the first is you have the right to know the full effects of medications prescribed to you, including the side effects that can accelerate and exacerbate the underlying cause of type 2 diabetes. And do you know there's some diabetes medications that cause weight gain? We know that weight gain increases insulin resistance and can raise blood sugars. Also, you have the right to have your type 2 diabetes medications reduced or eliminated if you undergo lifestyle therapies that improve your blood sugar levels. Okay, so that's from the American College of Lifestyle Medicine, and I encourage you to check out their type 2 diabetes Bill of Rights. So what's the goal of type 2 diabetes care? So in the past, it's always been management. Keep the numbers under good control. That was the goal. But now, and I put 1985 here because that's the year I graduated from my undergraduate nursing program. In 2022, what's the goal of type 2 diabetes? It's remission. Yay. And here is the latest definition of remission. And this was updated just last year. And remission is defined by the American Diabetes Association as an A1C of less than 6.5% without medication for at least 3 months. So anybody on the call achieved remission?
We did.
Okay, or want to make that their goal? Because that's what I want to encourage you to work towards. And the American College of Lifestyle Medicine came out with a position paper that remission should always be held as the primary clinical goal, and lifestyle medicine interventions that produce changes leading to remission should become the standard of care. Also, the option for such treatment should always be presented to patients in an informed consent process before other treatment offering minimal possibility for remission is prescribed. So this is what we're hoping for, and this is what groups like PBNSG and the Physicians Committee and ACLM are working on to teach student doctors and nurse practitioners and PAs that this is possible. So what are the roads to remission? How am I doing in time? All right, so there are 4 routes to remission that have been proven. So one is weight loss. The second is fasting or fasting mimicking diet. The third is bariatric or metabolic surgery. And the fourth is intensive lifestyle modifications. So I'm going to focus on the lifestyle modifications, which can also result in weight loss. And I'm not going to talk about the others, but if you've got questions at the end, we can talk about those routes as well. So ACLM says there are 6 tenets of lifestyle medicine, and these include physical activity, managing stress, forming and maintaining healthy relationships, improving your sleep, avoiding risky substances like alcohol or tobacco, and then healthful eating. And of course, our focus is on healthful eating, and that is actually the lifestyle intervention that has the biggest effect on blood sugars and on diabetes. And the American College of Lifestyle Medicine recommends a plant-based diet. That is their recommended diet, and they are one of many organizations now that recommend this diet. But one thing that you may not know about or may be curious about is this idea of how far do you have to go with diet in order to achieve remission. And there was this really interesting review of different studies that had as their goal reversal or partial remission of type 2 diabetes. And there were 2 groups of studies. In one group, there were 5 studies that actually had people achieve remission, full remission of their diabetes. And another group of studies, they did not achieve remission. And the distinction between the 2 groups, and this is busy, I apologize, I put a lot on here and I didn't separate it out, but basically the difference was the amount of weight loss. And in the studies where remission was achieved, the average participant in the study lost about 20 pounds compared to what these researchers called subtherapeutic dosing, where the average participant only lost about 8 pounds. And what I found the most interesting about this, so first of all, it really demonstrates that you can reverse diabetes without weight loss, especially if you're on the thinner side, but weight loss can really make a huge difference. And in these studies was shown to be critically important to achieve remission. And the amount of weight loss was important in participants who were significantly overweight. My takeaway, though, in comparing these 2 groups is those who didn't achieve remission, those who were in the subtherapeutic dosing group, were told to decrease their total caloric intake by 500 or 600 calories a day. And they didn't achieve remission. So Stephanie, I know you've heard this before. This is what we are taught to teach patients with diabetes. If you just take in 500 less calories a day, you're going to lose 2 or 3 pounds a week, and that's going to lead, that's going to improve your diabetes. And that's bunk. That's just not true. So you need to significantly reduce the amount of calories you're taking in. Now, that doesn't mean necessarily that you need to go on this really extremely low calorie diet. You can do it a little slower over a little more time, and it's actually a little more sustainable. In these studies that achieved therapeutic dosing, most of them were using some liquid meal replacers, and that's not what we're recommending. But the point here, the takeaway, I think, is that weight loss was necessary here for remission.
Dr. Trapp, quick question. Okay.
Yeah.
Is it true that if you've had type 2 diabetes for over 10 years, it's harder to achieve remission
Ooh, I'm going to talk about that. That's a great
later? Okay.
question. Yeah. So, so here I just want to make the point again. Could you do plant-based meals instead of meal replacements? And yes, absolutely. Every now and then the internet provides some fun little meme, and I love this one. If everyone ate like this, big pharma would be little farmy.
Yep.
All right, so the power of plants. So you're familiar with this. If you've heard me speak before, you've heard me talk about one of my first patients who had a huge success, and that was Ira. And we've remained friends to this day. At one point, he was on over 200 units of insulin. He'd had diabetes for over 10 years. And he is
Okay.
now off all of his medication, including his more than 200 units of insulin a day. He discovered that he had so much energy when he changed his diet. He no longer needed his antidepressant, and he challenged himself to start running or first walking and then running. And then he added biking and swimming, and he's now a two-time, I think it's maybe three-time Ironman. But you don't have to be an Ironman to reverse your diabetes. I don't know if you've heard me share the story of Debbie before, but Debbie is a nurse, and she was diagnosed with diabetes after having gestational diabetes 11 years earlier. And she was overweight. Her BMI was 40. Her A1C was 7.5, and she was put on metformin and diabeta, which is an older diabetes pill. It's a sulfonylurea like glinase or Amaryl glimepiride. And she was on there for a while. She was able to lose a little weight. She got her A1C down to 6.6%. And she was told by her doctor she was in great diabetes control. However, she wasn't very happy. She was on 4 medications, including liraglutide, which is Victoza, which costs $930 a month. And she was still on metformin. And she was on a blood pressure pill and a cholesterol pill, and she was nauseated all the time. But she was a good patient, so she kept taking her medications. So, and here in this picture, she's holding her first grandbaby. So, here she is in 2018, and she learned about a plant-based diet. And within just a few months, she was able to get off of her medications, and she lost a bunch of weight. And here she is now, holding her second grandbaby. She flew to Australia to catch that baby. And she wants everybody to know to encourage a plant-based diet.
Amazing.
So there's a great example of remission. And, she never got to the point where she needed insulin. But she was able to get off those other medications after many years. And it's true, we're taught that over time, the beta cells aren't able to keep up with high blood sugars, and their ability to spit out insulin goes down. But I don't think that's true. And there are studies that show that beta cell, the beta cells in the pancreas can be regenerated and can start making insulin over time. And now that's not necessarily true for everyone. And there are people who with type 2 diabetes are on insulin and may not be able to get off of it. But I found that the majority of my patients were able to, and that they were always able to greatly reduce the amount of medication or insulin that was needed with a plant-based diet. So all these different organizations now recommend a plant-based diet. Is there a learning curve to making this change? Absolutely. And here I want to point out, I have had this experience, as one of the people who asked a question earlier said, where a small number of people may see blood sugars go up initially. And this can just be a function of now you're eating more carbohydrates, but if enough time hasn't gone by to get the fat out of the muscle cells, blood sugars will still be high. And then the other thing is that, here's another case of if you're not going far enough with eliminating or reducing the fat in your diet. So if you're still, eating out and getting oil in the meals, that can lead to insulin resistance. So I encourage you to be patient if you haven't seen these immediate results. I was at I think this was the last live PBNSG program that I spoke at, and there was somebody in the audience, a husband and wife, and the wife's diabetes turned around right away when she made this change, but the husband's was much slower. And she said that it took a year and a half for him to get off of his diabetes medications. And I don't know if that was a function of, not really tight adherence to the diet or exactly what, but I guess my point is that, it's like riding a bike. You might fail, you might fall off a few times, but keep getting back on, because it often can get better over time if you stick with it. You can also not just use diet, but we know other lifestyle interventions like adding exercise and getting adequate sleep can make a big difference. And then follow up with your healthcare professional for medication monitoring. When you make this switch, watch for low blood sugar if you're on a pill or insulin that can cause low blood sugar. Be aware of the symptoms of low blood sugar. Even if you've never had low blood sugar, if you really make a dramatic diet change, you can start having low blood sugar, and that can be a dangerous situation. I wanted to throw out this word. Okay, we're just about done. Have you heard the term deprescribing? Okay, so this is a newer word, but it's getting out there. Doctors are learning this, and it's an essential part of good prescribing. And a good resource is, excuse me, this website, deprescribing.org. It's a Canadian website. They've developed guidelines for deprescribing 4 classes of medications that have been shown to be overused and problematic. And they've got a whole algorithm for anti-hyperglycemics. Those are medications that lower blood sugar. Now, the limitation here is it's geared for older adults, 65 and older, and it's geared for only those diabetes medications that can cause low blood sugar. But if you're on insulin or if you're on a sulfonylurea and you want support in talking to your doctor about cutting back on those, this is a good website for you. All right. Also, when you switch to a plant-based diet, if you're on blood pressure medication, you need to be careful. If you're on blood thinners, you may need to have your INR tested more often. And then finally, don't forget to supplement with vitamin B12. So instead of metformin, I encourage clinicians to prescribe fruitformin. Instead of Byetta, prescribe Beanetta. Instead of glimepiride, prescribe grainipiride. Oops, sorry. Instead of insulin, prescribe Vegulim. Awesome. So I just want to leave you with some really good resources. The first is Physicians Committee has a 21-day vegan kickstart. It's an app you can download on your phone. If you just go to the app store and look up 21-day kickstart, you'll find it. There's new recipes added all the time. It's in English and Spanish. Documentaries, you're familiar with these, but just in case you haven't seen any of these are great. The Game Changers, the target audience is men, so I highly recommend that one. And there's new documentaries coming out all the time. I need to update this slide. The Physicians Committee has an army of Food for Life instructors all over the country and actually all over the world. And you can find out about their classes, fflclasses.org, at this website. And they've got classes for diabetes as well as cancer prevention, survival, and kickstart for weight loss and health, et cetera, et cetera. There's also a free program going on now offered by the Physicians Committee. And this is a newer program. It started in September. I got to be part of the inaugural 8-week series. And it's going to be repeated indefinitely, and it's free. And it's every Tuesday at, I think, 3 o'clock Eastern. And you can go to pcrm.org and just put in Fight Diabetes with Food, or you can go to this website to register for the class. So it's every Tuesday. It just started again February 1st, so you can jump in now if you're interested. And they have guest speakers every week, and it's just an hour. There's recipes, just great resources. And it's also meant as kind of a support group. So even if you've taken it, you're welcome to come back, jump in anytime. Another good resource is with the plant-based nutrition support group. No, I'm sorry, the PPOD, plant-based prevention of disease. PPOD offers conferences every year, and their next conference is going to be live, we hope, May 21st and 22nd in Ypsilanti, and I'm one of the speakers. And these are just amazing live programs. This one's 2 days. The food's great. It's going to be Saturday afternoon, Saturday evening, and then all day Sunday. So I encourage you to check that out and sign up for updates about this conference. And then I mentioned the American College of Lifestyle Medicine. If you do not have a doctor or nurse practitioner who's board certified by ACLM, you can visit Lifestyle Medicine and search for a lifestyle medicine clinician. I looked to see who was in Michigan today, and there are 3 pages of clinicians. I'm not on here because I'm not currently seeing patients in my consulting role with the Navajo Nation, but there are a lot of great clinicians, and many are around the Metro Detroit area. And then lastly, what to do with those medications that you're no longer taking. So please don't just throw them in the trash or flush them. You can Google online where to, there are drug take back programs that you can drop them off at local pharmacies or police stations, or at the very worst, you can mix them with wet cat litter or use coffee grounds and put them in a sealed container in your trash. And I am going to end there. Oh, no, I'm not. I'm going to say, you've heard this quote from Dr. Williams, past president of the American College of Cardiology. There are 2 kinds of cardiologists, vegans, and those who haven't read the data. And I would say there are 2 kinds of endocrinologists as well. And we need more to read the data and to embrace this lifestyle. So I'll end there. Remission is possible. And let's open it up for any comments or questions.
All right, we've got a whole bunch. I'm going to dive in here. Okay, okay, the question was, can you have non-dairy sour? Oh, can you not have non-dairy sour cream because of the oil? What are your thoughts on non-dairy sour cream? So
Mary McDougall has a non-dairy sour cream recipe on her website, drmcdougall.org, and I'm sure there are other recipes that you could make without adding any oil at all. Usually they use tofu, but you know, you're not making a whole meal out of sour cream. If a dollop of plant-based sour cream on your plant-based chili encourages you to eat a big bowl of vegan plant-based chili, then I would say that that's a good choice.
But there's fake sour cream, like at the better than sour cream, and that has palm oil in it. So that you don't want anything with
so don't
oil,
buy it.
But tofu is just natural fat that's in the soybeans. Yeah. Okay. Let's see. Oh, there was another one up here. About checking blood sugars. Hold on. If daily check of, I'm sorry. Is daily check of blood sugar levels with a finger prick helpful or necessary?
Wow, that is a really individual question. Mm-hmm. I would start with, what is your healthcare provider recommended? There are studies that have shown that people don't live longer by checking their blood sugars, but if it helps you to stay motivated or to give you feedback on what you're eating, then I would say, go for it. I really had a range of testing among my patients, just depending on, like, number one, if you're on a medication that can cause low blood sugar and you make a diet change, then it would certainly be important to test anytime you don't feel well. But if you're just testing to see, the overall progress, and you want to take a day off here and there, save the expense of the strip, save the wear and tear on your fingers, I would ask your clinician and just see what they recommend for you.
All right. Well, I think that's most of our questions, and our time is about up here. So yeah, I want to thank Dr. Trapp. I learned quite a bit about those resources at the end. I was really excited. It's funny, I gave almost this exact same presentation earlier this morning. So it's the same. Like, I love Dr. Bernard's little schematic there with the cell and intracellular lipid.
Yeah.
Do we have a question here from Jill, or is that a clap? That's the clapping emoji. Okay, gotcha. Yay. But yeah, thanks so much, Dr. Trapp. We so appreciate your time and your knowledge and sharing your expertise with us. And if anyone has any questions for PBNSG later, you can send an email to connect@pbnsg.org. But yeah, thank you very much. Thank you everyone for attending tonight. And yeah, we'll look forward to seeing you again at some of our other meetings. All right.
Thank you so much, Stephanie. And thank you everybody for being part of this with me tonight.
All right. Thanks, Dr. Trapp. Good night.
Thanks for watching and for being a part of the PBNSG community. If you found this video helpful, be sure to give it a thumbs up and subscribe to our channel for even more plant-based insights, expert interviews, and delicious recipes.